So good evening, everyone. My name is Tina Gregg. I'm a nurse practitioner in Flowood, Mississippi. I am part of the GAP MASLD and MASH community network and hoping to help educate everyone tonight. So our topic for discussion this evening will be pharmacotherapy for MASLD and MASH. My slides are moving a little slowly, so just bear with me if you can. Okay, so here's a QR code for you to scan to record your attendance for the meeting if you haven't already done so. Okay, so let's start by taking a look at the current treatment framework for dysmetabolic management in MASLD. So the goal is not just to treat the liver, but to address the whole metabolic picture. This approach has three components: control of obesity, to reduce the cardiovascular risk, and obviously to target NASH. So in regards to obesity control, weight loss remains the cornerstone of therapy and will continue to do so. So a modest 7 to 10% reduction in body weight can significantly improve liver fat, inflammation, and also fibrosis. Lifestyle change is the foundation, focusing on dietary patterns like Mediterranean diet, which has the most data to support MASLD improvement, and then also regular physical activity. Guidelines recommend a minimum of 150 minutes per week. So if we, on a daily basis, this would be 30 minutes 5 times per week, minimally. So as we all know, lifestyle management is not always easy. It can be very difficult to achieve and definitely to sustain. Patients are not always successful. So sometimes additional help with weight loss can be needed in the form of medication therapy or other regimens. GLP-1 receptor agonists and dual GLP-1 GIP agonists like semaglutide or tirzepatide that promote weight loss and improve liver histology should be certainly considered for treatment. And then for patients with severe obesity, bariatric surgery is highly effective and should be discussed. So on to the next component, which is reduction of cardiovascular risk. Of course, this is very essential because most patients with MASLD will die from heart disease and not liver failure, just to be straightforward about it. So, that's a really scary thought when we tell patients that. So we definitely want to try to reduce or help them reduce their cardiovascular risk. With this, tight control of type 2 diabetes, hypertension, and dyslipidemia is necessary. And keep in mind that statins are safe in MASLD. So the risk is not increased in MASLD of statin-induced liver injury. So we definitely want to recommend these medications. We get that question in clinic quite often from providers and also from patients. Okay, and so finally, the third piece of the pie is targeting NASH directly. And of course, we want to do that. So options for this can include vitamin E for non-diabetic patients, pioglitazone for those with diabetes, and resmetirom, which is a thyroid hormone receptor beta agonist, recently approved about 1.5 years ago for patients with MASH and fibrosis. All right, so let's all be mindful that successful MASLD management requires an integrated approach addressing the weight, the metabolic and cardiovascular risk factors, and of course, treating the liver disease itself. Okay, so what about these GLP-1 receptor agonists that I mentioned? So these are naturally occurring in our body. We all have this, right? So after food ingestion, endogenous GLP-1s stimulate glucose-dependent insulin secretion, suppresses glucagon, delays gastric emptying, and directly acts on the hypothalamus to promote satiety and reduce energy intake. So these are analogs of the gut-derived incretin hormone, glucagon, like peptide 1. That's a little bit of a tongue twister. So in essence, GLP receptor agonists lower blood glucose and cause weight loss. Okay, so what is the role of these GLP-1s in hepatology practices? So in the Essence clinical trial, semaglutide at a dose of 2.4 milligrams once weekly successfully met both primary histological endpoints at 72 weeks. And this was showing significant MASH resolution without worsening of fibrosis and significant improvement in liver fibrosis without worsening of MASH. So we need to consider administering GLP-1s for overweight MASLD patients with a high priority given to those with MASH and certainly with stage F2 and F3 fibrosis, for which this is now FDA approved as of August of 2025. So in regards to GI providers, there's some considerations that also need to be given to the GLP-1s. Because this delays gastric emptying, the risk of aspiration on anesthesia is increased. So when we're thinking about scoping these patients, so doing our EGDs and colonoscopies, we need to consider this risk. And guidance is now recommending that the patients hold their dose for at least 7 days prior to their procedure. And if not, we need to really, consider canceling or rescheduling these procedures. Vitamin E at a dose of 800 international units per day was studied in a landmark trial called the Pivens trial. And this showed that vitamin E improved liver histology in non-diabetic adults with NAFLD. Of course, now we call this condition MASLD. Diabetics were not studied in this clinical trial, and so it is not recommended for patients with diabetes. So approximately 43% of patients showed histological improvement. So that's pretty good. Of course, not all patients respond, and we can't use this in hypertensive patients because of the bleeding risk at such a high dose, or in diabetic patients because we just don't have that data to support it. In regards to guidelines, in 2023, AASLD suggested that vitamin E may improve NASH in non-diabetic individuals, and this could be considered for use, while the 2024 Triple European Guidelines did not recommend it as a MASH therapy due to limited efficacy on fibrosis and also the potential risk of bleeding and some concerns over possible prostate cancer. So in the same Pivens trial, pioglitazone was also studied at a dose of 30 to 45 milligrams per day. And this medication obviously can be used in patients with or without diabetes. So while the Pivens trial showed that there was no benefit of pioglitazone over placebo for the primary outcome improvement in histological features of MASH, there were benefits of the secondary outcome with improvement in the cardiovascular risk. So for this reason, then we can consider using pioglitazone. Some of the downsides of using this drug, though, are potential risk of weight gain, which is discouraging to the patients because we ask them to lose weight and then we prescribe a drug that causes weight gain. There's also some risk of edema and bone fractures particularly in women. And then also there's some question of increased risk of bladder cancer. So if we decide to use this drug, obviously we need to select our patients carefully and have that conversation with the patients about the risk and benefits. And finally, we have a FDA approved, the very first FDA approved liver-targeted therapy called resmetirom. So this was approved, it gained conditional approval in March of 2024 in conjunction with diet and exercise, super important, for the treatment of adults with non-alcoholic non-cirrhotic steatohepatitis, NASH, which we now refer to as MASH. And this is in patients with moderate to advanced liver fibrosis, so stages F2, F3 fibrosis. Resmetirom is a thyroid hormone receptor beta agonist, so it's specific to the liver, works directly on the liver, not systemically. It selectively binds to and activates the thyroid hormone beta receptor in the liver. Okay, so what is a physiological relationship between the thyroid and the liver? So there's a close metabolic relationship between these two. So the thyroid gland produces T4 and T3 under the control of TSH. The active hormone T3 binds to thyroid hormone receptors, alpha in the heart and the brain, and beta, which is primarily found in the liver. When T3 activates thyroid hormone beta in the liver, it promotes fatty acid oxidation, it improves cholesterol metabolism, and it reduces fat synthesis by regulating certain pathways in the liver. So this effect helps keep liver fat low and metabolism efficient. So when the thyroid signaling is reduced, even mildly, fatty acid oxidation declines, lipids build up in the liver, and steatosis can progress to MASH. So targeting thyroid hormone beta with resmetirom allows us to harness a natural metabolic pathway to treat MASH. So let's take a look at the MAESTRO-NASH clinical trial. And this was the trial that helped gain FDA approval. It's an ongoing phase 3 randomized controlled trial of resmetirom in NASH with liver fibrosis. So the trial studied adults with biopsy-confirmed NASH, MASH, with fibrosis stages of 1B, 2, and F3. So there were 966 patients in this clinical trial. They were all distributed evenly into 3 groups, an 80 milligram resmetirom group, a 100 milligram group, and placebo. There were 2 primary endpoints at week 52, and resmetirom met both of those endpoints. So those endpoints were, number 1, NASH resolution, which included a reduction in the MASLD activity score by at least 2 points with no worsening in fibrosis. And then number 2, an improvement or reduction in fibrosis by at least 1 stage with no worsening of the MASLD activity score. And again, resmetirom met both of these endpoints. So in regards to safety, it was found to be an extremely safe drug. Diarrhea and nausea were the most frequent side effects that were obtained in the study. The incidence of serious adverse events was similar across all 3 groups, okay? So when we look down at diarrhea, there was about a 30%, diarrhea was about 30% compared to about 16% with placebo. Nausea, approximately 20% compared to 12.5% with placebo. And then again, the serious adverse events were equal among all groups. In regards to the primary endpoints that we discussed earlier, resmetirom 80 and 100 were superior to placebo with respect to the NASH resolution and also improvement by liver fibrosis by at least 1 stage. So looking down at the bottom, in the resmetirom 80 milligram group, 25, almost 26% achieved NASH resolution, and 30% in the 100 milligram group, as compared to the 9.7% in the placebo group. In regards to fibrosis improvement, we see over here on the right that it was approximately 25% in both groups, as compared to 14% in the placebo group. So, you know, to me, if I have a patient or myself or family member that has F2 and especially F3 fibrosis, and I can reverse that by one stage and try to stay away from cirrhosis, then that's a big deal. So this is really exciting news when this received FDA approval. And of note, this clinical trial, this data in the MAESTRO-NASH clinical trial was 52 weeks, but this study is actually going to go out to 54 months. So as we go along, we're certainly going to obtain so much more data on response and, any safety data and that sort of thing. Okay, so who are ideal patients for treatment with resmetirom? So as I mentioned earlier, it's studied only in adults, not children. So adults with non-cirrhotic stage F2, F3 fibrosis, okay? And it is FDA approved only in conjunction with diet and exercise. And this is important to know because some of the payers are actually requiring this. They're requiring the documentation on diet and exercise. And sometimes they're even asking, if patients have failed or achieved weight loss and made the dietary and exercise, changes and improvements. Okay, so when we look at any medication, there may be potential for drug-drug interactions, and that is the same with resmetirom. So on the left are medications that we want to avoid completely if patients are on resmetirom, and this is really important to know because, this may be a long-term medication, and so we need to be familiar with, with these drugs. So some of the more common ones, I guess, to note is cyclosporin, which we can see in our post-transplant patients. And then voxilatravir is one of the agents that's in one of the Hep C treatment regimens. And then clarithromycin, of course, we can see that as well. So in the center are drugs that we can use, but they will need to have a dose reduction. So I think, the most notable of this is the clopidogrel, the Plavix. And so with our patients having, being at high risk of cardiovascular disease and having these types of issues, then we're certainly going to see patients, on that medication. And it's safe to do so. We just need to dose reduce. So in addition to the 80 and 100 milligram dose that I mentioned earlier, there's also a 60 milligram dose that we can use in these particular circumstances. And on the right side, these are medications at increased risk of exposure due to resmetirom. So these medications concentrations can be increased. And I think the most notable ones in this column are the statins because many or most of our patients are going to be on statins. And it's okay to do so, but there are maximum statin dosages that are allowed, and these are listed in this column for you. Okay, so other considerations that we need to think about and, ongoing data will be collected and forthcoming to help us learn to monitor these patients. So basically, in regards to duration of treatment and monitoring, this ongoing evaluation with MAESTRO-NASH trial, likely we will need to and want to restage the fibrosis and the steatosis with non-invasive tests such as VCTE, PDFF, CAP, or ELF. And if you want to know more about these tests, there are actually videos and webcasts on the MASLD, the GAP MASLD community network that you can go back and listen to get a better understanding of these tests. I do recommend trying to stick with the test that you initially staged the patient with or, evaluated the patient with so that you will have that for comparison, if insurance will approve you having that test again. And again, expert panels are currently working on cut points and periodicity for testing. There is a great guidance that was published last year by AASLD, specifically in regards to resmetirom. So who to treat, how to monitor, how long to treat, it's just really, really good. Very easy to read. So I recommend that you certainly take a look at that when you can. Other questions that remain. Widespread resmetirom use, of course, will be dependent on insurance coverage. So can't treat them if insurance doesn't pay for it. And then again, when do we stage, restage? When do we order additional labs to monitor these patients? Those are questions that remain. We have some basic guidelines now, but as we collect more data, we'll know more about that. And what is the duration of treatment recommendations and when to discontinue treatment? Right now I'm telling my patients that this is probably going to be a long-term therapy as far as we know now. But, questions remain. What if a patient resolves their steatosis, and their fibrosis? What do we do then? So we will, of course, receive some guidance from, all the different agencies, that will help us along with this. And also just, to note, multiple agents are currently in clinical trials, and there are a lot of them. So we're likely going to have more options in the future. And, I expect this to be a disease that's going to require multiple agents for treatment, in a lot of people, kind of similar to diabetes or some of the other, conditions that we manage and see these days. Okay, and so this ends my program. Here's a QR code if you want to go and visit the GAP MASLD MASH Community Network page for those, videos and webcasts, and also wonderful information on disease states. And there's also a great Resmetirom webcast, if you're very, very detailed, if you're interested in learning more about this. And finally, there's a QR code if you'd like to complete a short survey, share your thoughts on today's presentation, and any feedback that you want to give is certainly appreciated.